Word on Health, the report with its finger on the pulse of popular medicine, with Paul Pennington. Word on Health, for your very best of health.
Its evolutionary rate, it's claimed, is 3 or 4 times faster than that of the fastest seasonal flu. Its constant change accelerates the number of susceptible people. The latest COVID-19 variant that's hitting the headlines is XEC, that according to research from the University of Southern California, should arrive with symptoms in a specific order, starting with fever, followed by cough, sore throat, muscle pain or headache, nausea, vomiting, and finally diarrhea. Although unpleasant for many, they will recover. But with every COVID-19 infection, there's an increased risk of developing long COVID. Doctor Margaret O'Hara is from the Long COVID Support Organisation.
Even if you're getting COVID and it's just a sniffle and you're not that bothered about it, you don't know what damage you are accumulating. It doesn't matter how many times you've had it before and been fine. The next time you get COVID could be the time you get long COVID.
Long COVID refers to symptoms that impact for weeks, months, even years after the acute phase of a COVID-19 infection has passed. In terms of prevalence, before this new variant came along, how many people were estimated to be living with long COVID?
The latest data that we have is from earlier in the year. It's been around 2 million for the past couple of years. And what's increasing is the number of people who've been living with it for longer. People from the first wave, still with long COVID, still haven't recovered. So it's like running a bath with the plug out. The hope was the tap would be turned off while the plug was open and you would eventually get down to a low number of people at any given time who have long COVID. Again, that's not happening. It looks like if there are people recovering, they're just being replaced by new people who are getting long COVID, or it could be people who've had long COVID before, have recovered, and then get COVID again, and then get thrown back into the long COVID pit.
Whilst long COVID affects every person, including children, differently, common symptoms include chronic fatigue, difficulty breathing, brain fog, and joint pain. It can affect multiple organs adversely and significantly impact quality of life, even in individuals with mild initial COVID-19 infections.
Things don't remain the same all the time when you've got long COVID. If you become ill and you're not used to being ill, you can kind of hang on for a bit with maybe your job, with your family situation, your home and so on, thinking, I'll get better eventually, I'll be on sick leave now, I'll just use my savings for the moment and I'll hang on. But after a couple of years, it becomes apparent that no, actually, this isn't changing. You've got to make a change to your life. You might have to give up work. You might have to move back in with your parents. There's a lot of that going on because they just can't hold on any longer, hoping that something is going to come up in terms of a treatment that will work and allow them to go back to their life. Or you've gone back to work, but you're really struggling. We're seeing those creeping up and up and up. And I think they will continue to creep up and up and up as more and more people get long COVID. And then the people that have had it for a long time just can't cope anymore.
Vaccines offer a certain amount of protection from developing long COVID. There are treatments for specific symptoms of it, and there's talk and research into repurposing drugs from other conditions. But as yet, there is no cure. And I know from talking to you off microphone that there is understandable frustration in the long COVID community that more research isn't being done to find effective treatments, and a sense that people with long COVID have been forgotten, which is why your support organisation exists.
We have a very large support group which has 67,000 people in it from all over the world. We have a research group which focuses on scientific research, and we have discussions of data that's coming out on anything that might help. We have our website. The website provides a lot of information around symptoms and signposts to sources of help and information. The support groups themselves offer solidarity, I suppose, validation, just somewhere you can have a moan and a rant with people who will understand completely and give supportive messages back to you. But you also get hints and tips and just the stuff you need to cope with the stuff you're going through.
My grateful thanks to Dr. Margaret O'Hara. To find out more and to link through to the Long COVID Support Organisation, visit our website, wordonhealth.com. That's wordonhealth.com.
Word on Health, for your very best of health.
Around 10 million people in the UK are estimated to live with a form of Raynaud's phenomena. Primary Raynaud's is the more common and typically less severe form. It occurs on its own without being associated with any other underlying health condition. Secondary Raynaud's is less common but more serious. It occurs as a result of another underlying health condition, often an autoimmune or connective tissue disease such as scleroderma, lupus or rheumatoid arthritis. Despite its prevalence in the rest of the population, research shows shows that less than 5% of us have ever heard of it, and 36% believe it's contagious, which of course it isn't. Sue Farrington is CEO of the charity SRUK.
Raynaud's phenomenon is a circulatory disorder. It's where the blood supply to the extremities is affected. So that's fingers, toes, ears, nose, and even nipples. The small blood vessels become extremely sensitive to changes in temperature, or even we found stress can bring on a Raynaud's attack.
Sue, how might a Raynaud's attack manifest itself?
The first signs that you may notice are when your fingers and toes are feeling very, very cold. You may notice colour changes in the affected areas. They can go white and then go to blue and red. And a lot of people experience numbness, tingling or pain in the fingers and toes. And then as they start to warm up, there's a real kind of stinging or throbbing pain that happens.
Although the severity and frequency of symptoms can vary widely from person to person, I know from talking to people who live with it, it can be extremely painful.
Imagine plunging your hands through the ice of a frozen pond and leaving them in the water for several minutes. Then take them out and run them under a really hot tap. And then the searing pain that you would feel as your fingers are kind of recovering to those extremes of temperature is something that people with Raynaud's phenomenon frequently experience.
Research into the genetic, immune and environmental factors involved in Raynaud's is ongoing. Do we have any indication as to the age and gender bias in its prevalence?
It's not age specific, so anyone of any age can develop primary Raynaud's. It's quite rare in young children, but more common in teenagers, and then may subside and not return. For those where it comes on later in life, it certainly affects far more women than men, I would say 2/3 to 1/3.
I know there's no cure at present, but are there things that people can do to minimise the frequency of attacks?
There are a number of things that people can do, making sure that your hands are warm before you put on gloves to go outside, wearing many layers rather than one thick item, and with your hands maybe wearing a pair of thin gloves before you put on an extra thick pair of gloves. There has been identified a link between smoking and Raynaud's attacks. Given it's a disorder of the circulation system, gentle exercise can help improve the circulation. And then there's other things that you can guard against. So if you want to kind of get anything out of the fridge, we often say to people, if you are prone to quite serious attacks, make sure that you wear insulated gloves. And these are lots of hints and tips that our community is sharing online.
As I highlighted in my introduction, it's estimated that cumulatively 10 million people in the UK have Raynaud's phenomena. However, many of these cases go undiagnosed because symptoms can be mild. Many people don't seek medical advice, or they attribute their symptoms to just cold hands rather than an underlying condition. When should we be talking to our doctor about Raynaud's?
If you are having regular bouts of this where your hands are going from white to blue and then to red, you may also start to get ulcers on your fingertips, and then you absolutely must go and see your GP because it can be a sign of an underlying autoimmune condition, scleroderma. And although that's very rare, this is a condition that can affect different organs in your body, and so it's really important that you have that identified.
My grateful thanks to Sue Farrington from SRUK. To find out more, visit our website, wordonhealth.com. That's wordonhealth.com.
Word on Health, for your very best of health.
Charcot-Marie-Tooth disease, or CMT as it's otherwise known, is an inherited neurological disease that affects the peripheral nerves. There are many types of CMT. In the UK, some 25,000 people are thought to have a form of it, making it the most common inherited neurological condition. However, many of us are not aware of CMT, even within the medical profession. In a recent survey conducted by the charity CMTUK of people living with CMT, 67% felt that less than 10% of the UK population had heard of it. The chief executive of CMTUK is Simon Bull.
In terms of daily lives, people haven't heard of it. It's kind of hard to explain to people what you have and what the condition involves. There are so many things to it, so many symptoms, so many ways it manifests itself, so many different ways that it affects individuals, that it's quite hard for people to appreciate or understand what sufferers are going through. Obviously, if the medical profession are not aware of the condition, it may take longer to get diagnosed because there are other conditions that may manifest in a similar way.
Simon, it's classed as a rare condition, and many general practitioners who may not have come across a case of CMT might not instantly recognise it and refer a patient on. Once a potential patient gets to see a consultant, where do we stand in terms of specialist doctors and consultants that can help?
We certainly have clinicians who know all about CMT. Professor Mary Riley at the National Hospital for Neurology and Neuropathies is perhaps one of the leading experts probably in the world on CMT, and she has an excellent team. There is a Centre for Excellence in Tooting, St George's, and there are steps being taken to improve that excellence across the country. But neurology as a whole is quite a neglected area. I feel there are parts in the country where you can't get the support you need. You can't get an appointment with a neurologist. For example, the North East has been very difficult in the past.
What steps is the charity you represent taking to boost medical awareness and provide support to people diagnosed with CMT?
We work closely with Neurology Alliance and with Genetic Alliance, try and support the campaigns they run. We provide awareness to doctors and the medical profession, so we try and have information for them if they need it. We are trying very hard to increase the number of people that we can reach. Quite often people come and they've just been diagnosed. Sometimes we find they're diagnosed and they're not given a lot of support or information. They're given the results, you have CMT, and then it's kind of like, get on with it. They call our helpline and we can go through what it means to them, how it may affect them going forward, what they can do to alleviate their condition to make things better. We have regional support groups in different areas which do different things. So they may meet in person, they may meet online, and they have their own WhatsApp groups where they can give each other hints and tips and what they can do to make things better.
As of now, there is no cure for this group of hereditary neurological disorders that affect the peripheral nerves, leading to muscle weakness, sensory loss and other motor impairments, especially in the legs and arms. However, treatments are available to manage symptoms and improve quality of life. These treatments generally focus on supportive care and symptom management rather than addressing the underlying genetic cause. Looking to the future, what does the treatment landscape look like?
Oh, there's certainly hope. There's certainly a lot of research going into gene therapy in the UK, in the States, across the world. In many areas, they're looking at CMT and how gene therapy can treat it. There's various genes that different CMTs affect, and it's not a simple picture, but it is a picture they're working on and they are making progress.
My grateful thanks to Simon Bull from CMTUK. To find out more, visit our website, wordonhealth.com. That's wordonhealth.com.
Keeping you in touch with the health and lifestyle issues that matter. This is Word on Health with Paul Pennington.